A very warm good morning to all. It's truly an honor to return to my alma mater and speak in front of this August gathering. I take this opportunity to thank Brigadier Poonam ma'am and her team for giving me this opportunity to speak in front of uh, you all. As an alumni of this institute, this place holds a special place for me, and it's a wonderful feeling to see how this institute still inspires us. Every advancement in technology evokes a range of emotions, and surgical simulation in surgery is no different. I shall be covering my presentation under the following heads. To begin with, I quote, when you put the patient first, you don't first practice on the patient. It is one of the bases of surgical training. Understanding the evolution of species is a saga spanning billions of years, shaped by countless adaptations, innovations, and extensions. The story of evolution is a testament of nature's creativity. In nature, change is the only constant. Or we may say, change is a necessity, or as we commonly say, parivartan ati nivaran. Simulation surgery has been existing over a century, over half a century, beginning with its 100. Predominant use in aviation industry, where it has been used for training of pilots, including their certification. And it has stood the test of time. And it is not limited to aviation industry, and it's slowly expanded and gradually spread out in various fields, including healthcare industry. The term virtual reality was first coined by Jaron Lanier, and it is also commonly referred to as surgical simulation. To define simulation, we may refer it to as imitation of real-world process or a system. And when we use this imitation in the field of surgery in a controlled and safe environment, it is referred to as surgical simulation. So we have two ends of a spectrum. One is the real world, and at the other end, we have the virtual environment with augmented reality and augmented virtuality somewhere in between. Typically, medical simulation can be broadly divided into these four types. The first two, the verbal and the cadaveric dissection, are the traditional ways of teaching, and the later two are the more recent or the newer tools of teaching. However, cadaveric dissection still remains to be the gold standard in surgical training because of its realism during surgical training. However, because of limited availability, cost, and ethical issues, including prion disease, cadaveric dissection has been cornered and gradually being limited to cadaveric dissection courses. These newer tools of teaching hopefully will fill this gap. Halstead is changed the course of surgical training, and he has been credited to promoting a residency program during his time. An aphorism coined by him, see one, do one, teach one, has been the standard of teaching. However, as we are all aware, surgical training is much more complex, and it takes immense time and training before one changes from a novice surgeon to an expert surgeon. The main goal of surgical training is positive transfer of surgical skill in an operating room. Surgical simulation provides us this opportunity by allowing us to learn through errors without endangering the patients, allowing different situational contexts, effective rectification of elements to be learned, and last but not the least, to also measure objectively the performance of the surgeon who is using these simulators. Let us understand the basics of surgical simulation. It begins with uploading good quality 2D images of a CT scan of a MRI, which is then reconstructed into a reference model with the help of computer graphics. Next, using certain software like the segmentation software and the meshing software, it is converted into a 3D vortex, which we can see in the center of this slide where the voxelman's photograph is being presented. Finally, attributes like bleeding, tissue interaction, tissue instrument interactions are added to the software with the help of software algorithms. So what we have are there are four components of a surgical simulator. One is a viewing station, and there are 3D glasses, which allows us to have a 3D image of the surgery being performed. The second and a very important part is the haptic feedback system, which gives us a tactile feedback. And now they have even added sound to it. Third is the foot pedal for controlling the drilling. And lastly is the central processing system. So this is an endoscopic sinus surgery in the voxemal system. It has also got options to change the instrument, as we can see on the right side. And the CT scans are displayed real time, which provides a feel of a neuronavigation. So finally, it's a machine which is trying to replicate a human brain. Simulation surgery began with the 3D reconstruction of CT scan in 1983 by Vanier. And no one would have wondered that this small step is going to be the future of surgical simulation. Over the next 2 decades, works from various people like Takagi, Harada, Sorensen et al. Led to the evolution of present-day simulator. Presently, in ENT practice, we have very basic model of simulators, like the ear examination simulator for training the residents and undergraduates. The AutoSim model for teaching otoscopy is also there. And there is a life form model which allows individual to learn extraction of foreign bodies, check tympanic membrane mobilities, and even perform basic simple procedure like myringotomy. Then there are the more advanced models like the operating room immersive microlanguage simulator, commonly called as ORIMS, which allows a surgeon to even biopsy a tumor. And then there is an endoscopic sinus surgery simulator. It was the first simulator for paranasal sinus surgery. This too could be included under the augmented reality aspect. Finally, the most recent and the most available one in the market is the voxemal surgical simulator. It has 2 modules at present. One is a temporal bone module, and the other is an endoscopic sinus module. In the armed forces, we have got 2 of them at present. One is at the Armed Forces Medical College, and the other is at AHRR with the temporal bone module. This could be as close to augmented virtuality. Any new technology needs to be validated. Several validation studies have been carried out both for the endoscopic sinus surgery simulator and the voxemal simulator. And mainly 4 aspects had been studied: the content or the reality of this surgical anatomy and the hand-eye coordination, the pace or the realism, that is the real tissue interactions, blood flow, tissue instrument interactions. Thirdly, to quantifiably differentiate between the levels of expertise of different surgeons who are using these simulators. And lastly, to predict the future performance based on this training. Although most of these studies are small in sample size, it has shown that improved performance in actual surgery can be achieved with training on these simulators, mainly for the surgical residents. However, the limiting factor is still the realism, and a lot needs to be done in this aspect. like any technology, it has its own pros and cons. The potential benefit being patient safety during surgical training. And there is emerging evidence of transferability of simulator skills to surgery. However, the technology is still nascent, expensive, limited availability, and limited to only certain procedures. And still, it does not incorporate the rest of the intraoperative team in the surgical intraoperative surgical team. So, what is the future of surgical simulation? Since yesterday we've been talking about artificial intelligence, so are the humans going to be replaced by humanoids? Presently, there are several technological advances progressing at the same time. Which of this is going to be selected and accepted, only time will tell. Or maybe it will be a combination of all of these. What I expect is, if these things are going to materialize and be true, we may reach a stage where the two ends of the spectrum join together, and it would become difficult to differentiate the virtual environment from the real environment. To conclude, we hope that the technology, with technological advancement, we do not become slave to it, and we still have a control over it. And I would like to end my presentation with this photograph. It is all of us to decide whether we are holding hands of technology or technology holding hands of ours. Thank you.
Wonderful presentation early morning, Sunil. 1 minute for any particular questions from the audience. So we move out. Thank you so much, Sunil.
We move on to our next speaker, Dr. Ankit Shah. He's MDS, qualified oral and maxillofacial surgeon. He's done his fellowship in head neck surgical oncology at Tata Memorial Hospital, Mumbai. He's a visiting consultant in head neck surgery and microvascular reconstruction at Ruby Hall Clinic, Pune, Sayadri Hospital, and all other major hospitals across Pune. He has almost 140 publications and 6 case reports in oral oncology. He's presently the director of Gratula Cancer Foundation, and he'll be speaking to us on role of AI technology in defining diagnostic and prognostic criterion in head and neck malignancies. Dr. Ankit Shah.
Thank you, sir. First of all, I would like to thank Department of ENT AFMC for giving me this opportunity to speak today. So my topic is role of AI technology in defining diagnosis and prognosis criteria in head and neck malignancies. Basically, head and neck malignancies. One second. So basically, head and neck malignancies are has a very complex anatomy and has various subsites. Again, it has gone. So the anatomy is very complex, and each subsites behave very differently. The role of chemoradiation is there in laryngeal cancers, which is not applicable in early oral cavity cancers. The HPV related oropharyngeal cancers behaves differently as compared to non-HPV related oral cancers. So each subsites behave quite differently, and it is very difficult to give a common summary for all treatments. The prevalence of each subsite is also different. So these are the various challenges which we need to face. And the most important thing is the early detection and the early treatment, which will be very useful for a good prognosis of the patient. So what are the diagnosis related challenges? So first of all is the lack of awareness. So many of us must have faced, we being the qualified surgeons work in a tier 1 city, but most of the patients still come from the peripheral. Even the general practitioners at their level are not able to recognize the clinical picture also, or recognize the disease also. There is even not accessibility for CT scan or MRI scan. There is also underreporting. Hello. There is also underreporting of imaging reports. There are difficulties in the histopathological reports as well, where we can see clinically there are malignant features, but histologically it has not been proven yet. So these are the lot of issues we face in day-to-day practice. Even the advancement like PET scan has their own limitations, where we cannot detect micro deposits or circulating tumor cells at molecular levels. So these are the diagnosis related challenges what we face in day-to-day practice. And these are the prognosis related challenges as well, where on the left side we can see the molecular and genomic related challenges which we face, which is not in our control, and the treatment related changes which are partially in our control, but at some point of time that also we can't answer the questions of the patients, like what is the prognosis of the particular disease. So this is where AI is introduced in head and neck malignancies, where all these diagnosis and prognostic challenges can be solved, and we have a better answer for patient to give. So what is artificial intelligence? It has a very complex definition, but it makes our life easier. So where all AI has been used in cancer research, it has been used in screening, sensor-based detection, biomarker detection, self-diagnosis applications, in predicting of incidence, recurrence, and survival, and also in treatment where chemo medicines have been tried, AI-assisted surgery has been done, precision medicine, decision support system, and cell programming. So I'd like to first discuss about the mass screening. So how it has been done. There will be, it can be done at a tertiary cancer center or clinics and camps, where a rigid probe is used for imaging, that it will be recorded, and automated diagnosis will be there. And same thing can be reconfirmed with biopsy. And that is how in mass population, it can be, the artificial intelligence can be used in at least sort out some pre-malignant patients and malignant patients. Application of AI in tumor, in malignancy, it can be used in tumor imaging, cancer screening, tumor metastasis, cancer treatment, anti-tumor drugs, prognosis, mutation, and other applications. So how exactly artificial intelligence is used in tumor imaging? It is just the way like how Tesla uses in auto drives. First will be semantic segmentation, that it recognizes the group. Like how Tesla will identify where are the trees, buildings, roads, different cars. So first it will recognize the group of areas. Then it will mark the boundaries, like where all it is placed. And it will recognize the location, like in which area it is present, buccal mucosa, tongue, or whatever. So this is how it will recognize and segment the images. So in early diagnosis, AI can be used at patient triage. Suppose somebody are checking online symptom checkers, they can be sorted. General practitioners' decision, for them, it will be useful as a supporting tool. When they come to us, we can segregate them as per diagnosis, alert, and risk threshold. In pathology, it is being used where lesion identification, radiomics, and deep learning classification is done. For biomarker analysis with machine learning and deep learning, whole genome can be studied. In cases of recurrence and detection and prediction, these models have been used with the help of electronic old health records, and automated eligibility screening with electronic health records are also being used. So these are the various applications where early diagnosis can be is helpful with the use of artificial intelligence. So now we'll discuss about the prognosis criteria. So it is a precision medicine. AI can analyze large data sets, including genomic profiles, pathology reports, patient histories, to identify biomarkers and genetic mutations associated with head and neck cancers. This information can help in tailoring treatments based on individual patient profiles, optimizing therapy choices, and predicting response to specific treatments. So there are various prognostic tools which have been devised. By analyzing diverse data sources, including imaging data, reports, treatment histories, and outcomes, AI can develop prognostic models. So I'll just give you some examples like various models which has been tried in the head and neck cancers with the help of artificial intelligence. It is a systematic review article which they have studied almost around 20 to 25 AI used prognostic tools. And this is what the final outcome is. They have studied various endpoints like recurrence-free survival, distant metastasis-free survival, loco-regional failure, overall survival, tumor-related death, and disease-free survival. So these are the endpoints they have tried. This also tells us that the ability of algorithms to evaluate multiple endpoints are there. But the most important, and they have succeeded in developing prognostic models for overall survival and disease-free survival, which is what we need the most. These algorithms exhibit better accuracy than commonly used prognostic models, such as that rely on depth of invasion. However, prospective clinical trials are required to evaluate and use it as a tool for disease management. It also helps in improving treatment planning and enhancing radiomics and pathomics. I would also like to give example related to this. So machine learning to predict occult nodal metastasis in early oral squamous cell carcinoma. So they developed and validated machine learning algorithms to predict pathological lymph node metastasis in patients with clinically node negative oral cancers. So these algorithms used 5 clinical and pathological variables to predict the presence of occult lymph node metastasis and were trained using 782 patients. Machine learning consistently outperformed the predictive models based on tumor depth of invasion. So these studies have shown that machine learning or artificial intelligence will help in predicting occult nodal metastasis, and we can avoid clinically N0 neck dissections. At the same time, there's another study which was done by a machine learning prognostic system for loco-regionally advanced nasopharyngeal carcinomas based on tumor burden features. In this, they have used MRI scan to check the tumor burden of the nasopharyngeal carcinoma. And with the help of machine learning, they have concluded that high-risk patients who received induction chemotherapy and concurrent CTRT have a better 5-year distant metastasis-free survival than those who have only received. So such studies are being done, and it has been shown that this have helped in changing the treatment as well as prognosis. Another study I would like to quote is the artificial intelligence for HPV status prediction based on disease-specific images of head and neck cancers. But definitely it will not be as these algorithms were able to predict, but was not comparable to the routine P16 IHCs. And we need to exploit AI much in certain areas of the practice. Another model for predicting Ki61 positivity, it has also shown that it's a promising tool, but it can't be replaced. Real-time decision support and research and development are the other areas which has been working on to make it real-time support for the clinicians like us. I'd like to show the video where IBM Watson, IBM is a group of software company who are working with Sloan Kettering.
Cancer is the second leading cause of death in the U.S., and in the next decade, demand for treatments is expected to grow by 42%, creating a shortage
they have
of
given
1,500
us an example like
oncologists.
how a
Meanwhile,
real-time
medical
a patient sits in front of us and a
information
clinician
is doubling every 3
uses
years,
this
making it
software.
more difficult to keep up with the latest treatment options. Memorial Sloan Kettering has been training IBM Watson to help close the gap, as this live system example illustrates. Let's say I'm a clinical oncologist preparing to see a patient. I step into my office, and instead of spending my limited time digging for relevant information, I select my patient from the queue and use Watson to summarize the relevant facts from the electronic health record and identify areas where more information may be helpful. Next, I can match the patient to a clinical trial, or review the suggested treatment plans Watson has presented. Green means higher confidence, while red means lower. To make recommendations, Watson has extracted knowledge from guidelines, best practices, 12 million pages of journal articles, and 200 medical textbooks. Watson provides a visual timeline of the treatment plan, as well as the plan's
200
suggested
medical textbooks are
modalities.
not possible
Again,
for us.
they're color-coded by confidence level. Each of the blue icons represents an opportunity to dig deeper into evidence. For example, I can review the specific sources behind each component of Watson's recommendation. Watson has also suggested additional publications for my consideration, an overview of the protocols for administering the treatment, and a summary of information of the suggested drugs. When I'm ready, I can select the treatment information to add to the patient's medical record and share with the patient. This demonstration has shown Watson's ability to create an at-a-glance summary of relevant facts from an electronic health record, to suggest confidence-scored individualized treatment recommendations specific to each patient, and to transparently expose source data that supports the recommendations. Watson is helping oncologists fight cancer.
Definitely, it is very useful to use such softwares, but there are definitely certain limitations and boundaries for AI and machine learning. The first most important is the decision-making limitations. We always want to take our seniors' help, which is not possible with AI. There are certain bias limitations. There is a lack of common sense. Certain areas where we need to use our common sense and make that treatment some changes. Even some trials can't be done. And there are the boundaries of machine learning, because this machine learning also needs certain training, which is done by IT people, software-based people, and it also requires different kind of softwares. And ethical considerations, how much will this be validated, needs to be checked. So there is another, just to show an article where there are limitations of the AI, where it has not been able to diagnose between precancerous and cancerous lesion, which is a very important need for us. And the most important need they have not able to prove yet. And what will be the future of AI?